Hi there, I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. I'm a medical oncologist, and welcome to this PrecisCa GI tumor board. I am joined today by a very esteemed faculty, and I'll start with introductions. Dr. Catenacci.
Hello, I'm Dan Catenacci. I'm a GI medical oncologist and director of the GI oncology program at the University of Chicago.
Hi, I'm Marty Weiser. I'm a surgical oncologist at Memorial Sloan Kettering Cancer Center in New York City.
Hi, I'm Darren Keyes. I'm both a interventional and diagnostic radiologist at the Piedmont South Imaging Center, covering 2 hospitals southwest of Atlanta.
Hi, I'm Pritesh Patel, a radiation oncologist focusing on GI malignancies at Emory University in Atlanta.
So here we have a 72-year-old female who smoked in the past and had a history of stage 2 T2 N0 squamous cell carcinoma of the anus. That status post definitive chemoradiation with 5-FU and mitomycin. Now with recurrent metastatic liver disease 3 years later, what are our recommendations for treatment? So this patient presented with anal discharge with no other complaints and an ECOG performance status of 1. The medical history is notable for hypertension and body mass index of 40 with morbid obesity. Has a 22-pack year history and quit only 2 years ago, but no alcohol or drug use, and no significant past family history. In regards to her oncologic history, in 2015, she was diagnosed with this anal squamous cell carcinoma, which was treated with definitive chemoradiation to 50 gray in 28 fractions with concurrent fluorouracil and mitomycin. 3 years later, a surveillance CT of the chest, abdomen, and pelvis reveals a heterogeneous hypo-enhancing mass within the anterior right hepatic lobe, measuring just under 7 centimeters, and a second peripheral right hepatic lobe hypo-enhancing mass measuring 1.3 centimeters, concerning for liver mets. A PET CT is performed, and the right hepatic dome mass has an SUV max of 6.9, and similarly, the right hepatic mass has an SUV of 8.5. Here is the imaging, and Dr. Keyes, please explain.
Sure. So we've got the top 3 images are just CT, contrast-enhanced CT images with IV and oral contrast. The bottom 2 images are fused PET CT images without contrast. So you can see the liver here is, it's a steatotic liver, but there's a irregular, rim-enhancing, irregularly shaped lesion in the right hepatic lobe that measures probably about 6 or 7 centimeters. You can see it on the axial image on the top left, and then also on the coronal image. Lower down in the liver on the top right image, you see a smaller metastasis, in segment Roman numeral, or segment 6 of the liver. That is similar in appearance, just much smaller. And, these are both consistent with metastatic disease. The PET CT findings show that it is a hypermetabolic mass with, increased FDG uptake. So these are all consistent with liver metastases.
So continuing on, the patient undergoes a CT guided biopsy, which confirms metastatic anal squamous cell carcinoma, no loss of MMR, PD-L1 is 0, MSI stable, tumor mutational burden indeterminate, ERCC1 is negative, and beta-catenin mutated. The patient is started on palliative carbo and paclitaxel for 2 cycles. PET CT follow-up reveals the right hepatic dome lesion is stable in size, measuring 6.2 centimeters, maybe subtly down from around 6.9. SUV max is 5.8. And the inferior right hepatic lobe lesion is smaller and shows a metabolic complete response. So the patient is then transitioned to 5-FU and cisplatin for 3 cycles. CT chest of the and abdomen and pelvis reveal progressive disease with at least 5 new lesions in the right hepatic lobe with no evidence of other metastatic lesions. So here's that imaging.
So I
Dr.
suspect
Chris?
when you go to PET CT images from May of 2018, it again shows that there's an FDG avid mass in the right hepatic dome. And then the image on the right is, I think, meant to show that smaller lesion that was seen on the lower side, on the lower margin of the liver that does not show any FDG avidity. So a complete response on that lesion.
And so, what are our treatment recommendations at this point? So this is a patient who has a anal cancer that's treated with definitive treatment 3 years ago, then recurs with biopsy-proven disease in the liver, gets carbotaxol, and has some evidence of response, but is transitioned to 5-FU and platinum. And I'm not clear on why that transition occurred when the patient was having some response. After that transition, it sounds like the patient is having progression in the liver. So maybe I'll start with you, Dr. Kreis. I mean, this is liver-only disease. Is there a role for Y90 chemoembolization in this patient?
I think there is a role in this patient with liver-only disease. It is an anal cancer. It's not, the Y90 has been most extensively studied for metastatic colon cancer. So this is a slightly different pathology, but certainly Y90 has been used quite broadly with other sites of metastatic disease. And I think a lesion like this in someone who's gotten a lot of chemotherapy and it's liver-only disease, and it's only involving the right hepatic lobe as well, which I think is important because you're going to be able to treat the right lobe in one setting. You'll hopefully take care of any micrometastatic disease that's available. You can spare toxicity to the left hepatic lobe. And I think they'd be a good candidate for it. I think the only thing that would give me pause on them, the liver does look steatotic, and a lot of times that's due to some of the chemotherapy, or just, the patient is obese and could have had a steatotic liver at baseline. So I'd want to be very careful about checking her liver function before, making sure that she's a candidate for the therapy.
Right, and that's something I was going to bring up for Dr. Weiser. I mean, this patient has right lobe dominant disease. Would they be a candidate for a resection? Or would you be nervous about that in this older person with who has progressed on chemotherapy, steatotic, obese?
Yeah, I think the latter. I think there are a lot of risk factors. Although there are select cases of anal squamous cell carcinoma that we do resect in the liver, most of them do act this way and progress. So we don't get a lot of mileage out of surgery. And I think the risk factors do make it a bit prohibitive.
So maybe the patient who had a longer disease-free interval and more favorable biology, maybe that patient, different scenario, you consider a resection for oligometastatic disease.
Yes.
Dr. Patel, do you see any role for SBRT for this patient, or it sounds a little too diffuse?
Yeah, and in the latest scan with 5 new lesions, I think if we were wanting to do a liver treatment, I would certainly defer to Dr. Keys for a regional treatment. But certainly, I think disease progression immediately prior to the local therapy always gives me pause. Want to see an effective systemic therapy first. And
so, Dr. Catenacci, do we have effective systemic treatment for this patient?
Yeah, I share the sort of question why there was a change there from carbotaxol to the cis-5-FU. Potentially there was some tolerability issue or whatever, because generally if something's working, we stay on that until there's evidence otherwise. So, assuming that we can't go back to carbotaxol, which there's not evidence that there's been progression on it, but we can't for whatever other reason, I would agree. I think we would be talking about locally ablative therapy with a TheraSphere approach or something like that, like already mentioned. Or, of course, we do know that immunotherapy, checkpoint inhibitors have demonstrated some benefit in this second line setting with a number of different PD-1 inhibitors, nivolumab, pembrolizumab, listed in the NCCN guidelines for this situation, has about a 25% response rate. And so makes some sense, especially if it was, multiple locations as opposed to just in the right lobe of the liver. Certainly we would favor that. But in this case, one or the other, or reserving the PD-1 inhibitor for later and going with ablation would be a reasonable approach now.
Yeah, personally, I think the real question is the liver function for me, right? To your point about the steatosis, because we know that those patients who do respond to IO respond very well, right? And would it not be unreasonable to offer this patient 2 cycles of nivolumab and then follow up close imaging? I guess, the data with radioembolization, I guess, in anal cancer specifically is probably lacking, I assume. Or, obviously in colon and liver cancers, it's a little better established. Would you agree with that, Dr. Kreis?
Yeah, I would agree. I mean, for if we were talking about a liver tumor, a primary liver tumor, or metastatic colon cancer, there's pretty good data depending on the stage of the patient. With anal cancer, it's a little more, there's a lot of different tumor morphologies that we use Y90 for. And generally, when you talk about just those other metastatic disease sites, the response rate is still reasonable. I wouldn't expect a complete response in this patient, but I would expect at least a partial imaging response. I think this would delay progression, of disease within the liver. The question with local therapy to the liver in these kind of settings is always, are you getting, are you really improving survival, or are you just, prolonging, progression in the liver? And that's always the question that I kind of tussle with the patients. But I think she'd still be a good candidate for it. There are some other ways too, where you can deliver the radiation in a more selective fashion in someone with kind of questionable liver function, where you can avoid, doing a whole lobe, especially for that smaller lesion. That smaller lesion on the right, and a lot of times too, you can combine modalities. If there's a larger lesion that we can deliver a focal area of radiation to, doing something that's called radiation segmentectomy. Some of those other smaller lesions might be amenable to a percutaneous ablation. So there's a lot of different things we can do with a patient like this, to try to optimize their local therapy.
And obviously there's an evolving literature, most of it preclinical, about whether or not there's synergy between locally ablative approaches and IO. Does radioembolization release neoantigens that then can be taken advantage of with an immunotherapy approach? I mean, I'm going to take the liberty here, though, unless there's strong objection, that maybe the first approach would be to discuss with this patient a PD-1 inhibitor, and keeping in mind, depending on the expertise available, if radioembolization might be something to consider. I think they would need some good assessment of their liver function and liver reserve, but perhaps maybe starting with IO, assessing response, and if they're having progression, maybe Y90 as a salvage approach.